Welcome, everybody. Good afternoon, good morning, or good evening, wherever you are, to this EUPSA ERNICA webinar. Is a format where we get the perspective of a pediatrician together with a surgeon. So today we are tackling the tough topic of achalasia, pediatric achalasia. We have two prominent speakers in the field. First of all, Professor Frederic Gottrand. He's a pediatric gastroenterologist from Lille, France, and Dr. Julia Brendel. She is a pediatric surgeon from Hannover Medical School. I also want to open this session with my co-chair, Professor Augusto Zani from Toronto Sick Kids, and the famous and beloved Gaia Tamaro, who is leading the EUPSA office. So we will start with the first speaker. The first topic, it is the conservative approach and the diagnostics by Professor Frederic Gottrand. He is a pediatric gastroenterologist in the Faculty of Medicine at the University of Lille in France. He's a staff member of the Department of Pediatrics at the Children's Hospital in Lille. He earned a PhD in pediatric nutrition at the Pasteur Institute in Lille. And since 1997, he is a professor of pediatrics at that institution. He's an active member of several pediatric societies, including the Aspergen, where he leads the esophageal atresia working group, also leading the French Reference Center on Congenital Esophageal Malformations. And he is the past president of the French-speaking group of Pediatric Hepatology, Gastroenterology, and Nutrition, and also past president of the International Network of Esophageal Atresia in OEA. Finally, he is co-chairing the ERNICA workstream for esophageal diseases, and he hosted the ERNICA meeting exactly 2 years ago in fall 2021. Lille is a great city. It was at that time a great hospitality, and we all have very warm memories about that meeting. On top, he's an outstanding clinician scientist with an age index of 73. So, Frederic, it's a great honor for us to have you with us this afternoon and to listen to your perspective, the perspective of a pediatric gastroenterologist on this not so easy topic of achalasia. And we are looking forward very much to your talk.
So thank you very much, and I'm very honored and very happy to discuss with you. You know, I'm a pediatric gastroenterologist. I'm not sure that there are many attendees from my fields, but I'm used to, for years, to work with pediatric surgeons in my hospital our worlds are very close, and I'm working on daily basis with Ronnie Sfer and his team in especially rare esophageal disease. So would like to start this talk talking about esophageal achalasia. To remind you in a few words, of course, I will focus on treatment, and Julia will talk about surgery and HLR myotomy, but I would like to first start with some background and some data to know a bit more what is really achalasia. So it's very, very rare disease. It's an acquired disease. It's not a congenital disease. And it's first a motility disorders. And very important to remain in mind that there are two main features in terms of motility. The first is the absence of or abnormal peristaltism. And the second one is a failure of the lower esophageal sphincters to relax and to open. So that's not only a question of less lower esophageal sphincter, but is mainly a motility disorder. And when we talk about treatment and outcome, of course, we have to keep that into account in mind. So there are two main treatments. I will go more in details about what are the options on treatment, but the two main treatments are endoscopic dilatation and cardiomyotomy. And cardiomyotomy can be performed either by surgeon, by HLR myotomy, and you know much better than me about that, or endoscopic, which is a POEM, perendoscopic myotomy. I will give you some input on that and some information on that. And what is very important is due to the rarity and to the low number of good studies and controlled compared studies, there are no clear consensus at that time on the best first line, either second line treatments. And when you try to look at the data in literature, there have been a systematic review there published 5 years ago, more than 5 years ago, showing that the data are not comparable because according to different studies, the outcome, the way of measuring efficacy, side effects, complication are quite different. So it's very difficult to really compare different techniques. So word of pathophysiology, as I mentioned, is an acquired disease where probably there is a first aggression, which is supposed to be viral, but it's not proved at all. And this aggression came in a predisposing genetic train, and they have been demonstrated that some HLA tissue are in favor or helps to the development of the disease. And that in that type of patients, there are an inappropriate autoimmune and inflammatory response, leading to lesion about the neurons from the mesenteric plexus and then to fibrosis. And at the end, they have a lack of the lower esophageal sphincter relaxation and a hyperistaltism of the esophageal body. And this is a disease where we are talking about. If you look now at the exact incidence and prevalence, you can see that the peak of the disease is 30 years of age. So it's mostly a disease for adults, but it can start very early, even in infancy, and it's very difficult to have the complete picture and diagnosis on that. Both sex can have an achalasia, but in pediatrics there are a slight increase of males compared to females when you look at every series. So we have data about incidence at new cases or prevalence, total cases, coming from 2 countries, the UK, where there have been 2 papers. The last one has been published in Active Disease in Childhood in 2011, and the more recent one in Netherlands, where they'll look at the health system coding, and so to know a bit more about pediatric incidence. And if you look at that and comparing to the number of births of children in France, as an example, it's 10 new cases per year in France, and a total in children less than 18, it's 150. And if you, for example, compare to esophageal atresia, it's 20-fold less frequent than esophageal atresia, which is already a rare disease. So meaning that it's very difficult to have good data and good series because of the extreme rarity of this disease. So the clinical presentation here is a table from a paper we published last year, looking at almost 100 patients about the French-speaking group of pediatric gastroenterology and nutrition. The mean age at the beginning of symptoms in 10 years, but as you can see, it can start as early as 5 or 6 years of age. There are usually a long delay from the symptoms, beginning of symptoms and diagnosis, because the symptoms are not cannot distinguish with other more common disease, like as vomiting of dysphagia of the left part of the screen. But also very important to note in children is that weight loss or failure to thrive is very frequent. Is in more than 50% of the children with an esophageal atresia are undernourished at the time of the diagnosis. And of course, there are some respiratory symptoms, recurrent pneumonia, chest pain, which is very difficult to depict in a child, of course. And then that explains why the diagnosis is very difficult usually. And the child can wait for months or years before the formal diagnosis is established. So to follow what happens before, mostly for the follow-up of the child, the ECART score was published a long time ago in adults. And you have here the ECART score, and a child is, or an adult patient is thought to be in a remission when the score is less than 3, but as you can see, there are at least 2 of these 4 characteristics which are very difficult in children. Weight loss, you can see that waiting for 10 kilograms of weight loss is completely inadapted for most of our children. And also chest pain, because children less than 6 or 8 years are very difficult to precisely show where the pain is coming from. So dysphagia, regurgitation, chest pain, and weight loss are the main symptoms in this score. So for the diagnosis, you need absolutely 3 examinations. The first is upper GI. The upper GI endoscopy is devoted to mostly eliminated other diagnoses. And you can see here on these 3 picture figures, eosinophilic esophagitis on the left, which can cause dysmotility and sometimes dilated esophagus. So you need absolutely an endoscopy and biopsy to rule out this condition. On the middle, it's congenital stenosis, which is not always complete and is sometimes very difficult to make the diagnosis. And on the right part, this is a leiomyome of the esophagus we had several years ago, and the presentation was typical of an achalasia, and only endoscopy shows these tumors in the esophagus, and then CT scan and surgery proved that it was not a pure achalasia, but it was a leiomyome of the esophagus. The second exam is barium swallow, is needed as a pre-treatment to see how the esophagus is dilated and to see the termination of the lower part of the esophagus as a peak, as you can see here. And finally, the gold standard of diagnosis is high-resolution manometry, which is mandatory to have the diagnosis. And if you are not familiar of high-resolution manometry, you have the upper parts, the upper sphincter of the esophagus, and the red color means that the pressure is high, and the blue color means that the pressure is very low. In the middle is the esophageal corpus, and in the lower parts you have this yellow and red line is a lower esophageal sphincter, so you can measure different metrics. But here you have a typical type 2 achalasia, which is the most frequent forms of esophageal achalasia, where you have a pan-esophageal pressurization, meaning that you have pressure at the same time at all levels of the esophageal corpus, and not a clear clearance and a clear difference in timing of the pressure from the mouth to the stomach. And in this case, also a very high residual lower sphincter pressure, which was 52 millimeters, and the norms is less than 30. So this is a typical case. There have been a Chicago classification several years ago, adapted for children, where you can see 3 different types of achalasia. The type 1, which is 15%, is complete aperistaltism. You see everything is blue in the corpus of the esophagus, so no contraction at all, as you can see here. And you have a high pressure here, and here you have the deglutition, and nothing happens. No pressure, no contraction. The type 2 is the pan-esophageal pressurization, when 20% of time you have a pressure in the whole part of the esophagus, and not this, you expected some line like that coming from the mouth to the lower esophageal sphincters. And the last type is type 3, where you are very spastic, very high pressure at the same time in different parts of the esophagus, which is only 16% of the case. So the type 1 is the most frequent one, and hopefully, at least in adults, in children, it's not so clear that the best prognosis after any treatment is a type 2. Coming now to the topic of my presentation is about treatment, and the first thing I have to say is that whatever the treatment you use, its aim is to reduce the pressure of the lower esophageal sphincters, and this is a palliative approach. You don't have any treatment, any efficient treatment to improve the peristaltism. That means that when you are happy with your treatment, whatever the treatment is, you didn't do anything about the peristaltism. Of course, if you reduce the lower esophageal pressure, or if the lower esophageal sphincter is more open, the child is better, but you don't have a curative treatment for that. As I mentioned, there are no consensus about the best treatment in children at that time. So what type of treatment do we have? First is medical treatments, and I will be very short because it doesn't work. You have here on the lower part of my slide the different receptors and mechanism of the contraction of the lower esophageal muscle with different calcium or AMP, which are explaining contraction, either relaxation. So isosorbide dinitrate is sometimes used in adults and never been used in children. I never see any paper on that. Calcium broker is nifedipine. It's blocked the calcium channel here, so it reduces the contraction. It has a very transient effect. It can be used in very early form of achalasia in small infant, when you don't want to go to dilatation or surgery on myotomy in the first step. But there are severe side effects. It's not well tolerated, so you need to have the infant or the child in your hospital ward to start with very progressive dosage of nifedipine. So it can be of help for some incomplete form or waiting for confirmation of the diagnosis. So when you look at the treatment, of course, you have endoscopy or surgery. So the first endoscopy is injection of botulinum toxin, which reduces the cholinergic stimulation of the lower esophageal sphincter. We'll come back on that in the next slide. Dilatation, either hydrostatic or pneumatic. Pneumatic is the most powerful, the most efficient technique, but the minimum diameters of pneumatic balloon are 30 millimeters, meaning that it is not adapted to small children at all. And then the quite new techniques of peroral endoscopy myotomy. I will come back also on that. And then surgery, but I will let, of course, Julia to develop this myotomy. So a word about botulinum toxin. It's quite easy to use. If you have some experience of injecting botulinum toxin in different area, it's very easy using a sclerosing needle through the endoscope. A maximum dose is 100 units in 4 different quadrants. There are almost no complication reports, but it's a transient effect. And as you can see on the slides, it's the largest series reported in children, 23. You see that the response was good. It is 19 of the 23 patients respond in a few weeks, but it's a transient effect. After 4 months, the effect was not there anymore. And the evolution were repeated injection, pneumatic dilatation, and most of the children were operated later on. So botulinum toxin is now only for selected patients waiting for another treatment, or for very, very severe cases with other malformation, or when you believe that a myotomy will not be acceptable for ethical reason or whatever. Pneumatic dilatation is leading to a mechanical stretching and delaceration of the circular muscle of the esogastric junction, and it respects the other layers of the esophagus. The most powerful is pneumatic, but as mentioned, you cannot use it in children less than 6 years and weighing less than 20 kilograms. So you need to have quite old children. There are quite a few complications. It's also an efficient techniques, but esophageal perforation is 1 to 2%. For a comparison where you are dilating an esophageal anastomosis for an esophageal atresia, for example, the rate of complication is 0.5 to 1%. So it's quite high compared to other dilatation, because using pneumatic is really a big stretch of the circular muscle, and so the risk of complication is quite high compared to other dilatation for other stenosis. So hematome, bleeding, chest pain, aspiration pneumonia. You can see on the left part here, this child we dilated a lot of feeding impacted, food impacted in the esophagus, in the dilated esophagus. So when you dilate, you have a risk of aspiration pneumonia. The GERD risk is quite rare in pneumatic dilatation. Here I report our experience where we compared in retrospective multicentric French studies in almost 100 patients, the first, second, and third line treatments comparing endoscopic dilatation and LR myotomy. And what I want to show you here is that the success was higher for LR myotomy compared to esophageal dilatation. But the other reason I put this slide here is that you can see that most of these children, either those with LR myotomy, have a second or a third line treatment, meaning that even you are happy with the result in the first months, many or some of these children will require a second line or a third line treatment later on because of dysphagia, recurrence, or failure to thrive. Here is a result in terms of duration or success rates. You can see here success rate. This line is the dilatation, endoscopic dilatation. So you see that after at least 1 year, the results fall down. And after 3 years, you have only 20%, less than 20% of these children successful with no symptom and no other treatment needed. And compared to LR myotomy, where the results are significantly better. But you can see also after several months and years that the result is not so good. And here, after 4 years, you have less than 50% of these children without any symptoms and who don't require another treatment. So that's the things. And when you compare complication of dilatation compared to myotomy, there are no significant difference. Although myotomy has, when you look here, 35% of complication compared to 29%. But and some difference, mucosal injury, you have in green myotomy and in blue endoscopic dilatation. And you can see, especially for GERD, no difference in the outcome about GERD in this patient and related to perforation. So now going to POEM, you know, it's quite a new technique. It was first reported by a Japanese endoscopist 20 years ago. And it's now more and more popular in adults and more popular in children. This is an endoscopic techniques of myotomy. It starts with a submucosal incision of the circular muscle layer of the lower sphincters with prolongation of the gastric side of the gastric junction is made by endoscopy. Efficacy on the short term, 3 to 6 months, is very high, 90 to 95% in adults. And the experience is dramatically increasing in children. I put here at least the last series in children report, and you can see in this year, in 2023, there are at least 4 studies from Japan, from South America, reporting series of 30, 40 children with outcome. It's not randomized control study against whatever another treatment, but we start to have good data about complication and at least the early outcome. So complication is quite low, 32%. It could be pneumoperitoneum, mediastinitis, or emphysema. The GERD is 20% at 3 years in many studies, but usually respond to PPI and don't need any fundoplication later on. So this is a picture where you can see, if you are not familiar with the techniques, the way it's proceed. It first starts with a submucosal injection of methylene blue and then a mucosal injection, and then the scope is introduced in the tunnel. And then when removing the scope, the endoscopist make a section of the myotomy section within the tunnel, and then it's end by 3, 4, or 5 clips to close the mucosa. And usually the child is sleeping in the hospital the first night and discharged the day after with a quite low rate of complication. So you have here in adults success rate on the more long term at 2 years is compared. There have been several studies in adults, randomized studies comparing LR via POEM, and you can see that the success is the same, more than 80% in this series on adults. Complications are not significantly different. It's 7% in LR versus 3% in POEM. And peptic esophagitis was a bit more frequent, is 40% in this adult after POEM compared to 30%, 29% in LR patient. And you know the reason is why anti-reflux fundo surgery is often associated to LR. In children, we have a similar rate of success in this series, and the complication you see I've already mentioned is mainly GERD. It's 20 to 30% in this series. So there have been a quite recent paper from China reporting a long-term outcome on POEM in children. And what is interesting in this paper is that they compare almost 50 children to 1,000 adults. They performed also POEM during the same time, and they didn't see any difference in complication between adults and children. They have a follow-up for 34 pediatric patients, and the clinical success was 97%. And the GERD occurrence is the same in adults and in children, and they have a measurement of quality of life, and it's significantly improved compared before and after in both groups after POEM. So what do you have as a recommendation? It's only adults recommendation. This is the consensus published almost 5 years ago by the adults, and there are only 2 recommendations for children. The first is that surgical or endoscopic myotomy is a preferred treatment for pediatric patients, especially for those age more than 5 years. And the botulinum toxin is not an appropriate first-line therapy in very young children, but it can be used in special conditions. So to finish, my take-home message is our oral pharmacotherapy is not particularly effective. Botulinum toxin can temporize symptoms, but is a bridge to a more definitive therapy. Pneumatic dilation, peroral endoscopic myotomy, or laparoscopic LR myotomy can provide durable symptom benefits. So thank you for attention, and I am leaving the floor to Julia, or do you want to ask questions at the time, or you are going to the end and then we see?
Yes, thank you, Frederic. Thank you very much. This was an awesome presentation. Well, our style is usually, our format is that the 2 presenters give their presentations. There are already, in fact, a number of questions for you in the chat, but we go ahead with Julie's presentation, and I will introduce her. I should say Julia, in fact, Brendel, is a Oberarzt a pediatric surgeon in Hannover Medical School and Children's Hospital. She trained in Hannover, but also did a research fellowship with Professor Prempuri in Ireland, where in fact studied congenital traumatic hernia in an experimental model. She has an interest definitely in upper and lower GI surgery, abdominal wall defects, and she is the ERNICA representative for Hannover. ERNICA is definitely growing bigger and bigger, and she's been participating to the guidelines, ERNICA guidelines on the management of gastroschisis, the Delphi for Hirschsprungs, and currently working, in fact, on an Achalasia consensus guideline of ERNICA together with ESPGHAN. So definitely Achalasia is one of your interests, Julia. So we're really looking forward to hearing your presentation.
Yes, thank you very much for this very kind introduction. I really hope you can see my presentation now and also hear me clearly.
Thanks.
So besides the surgical treatment of achalasia, I also want to say something later on about the follow-up and the long-term outcome of this disease. I have nothing to disclose. The surgical treatment for achalasia is the esophageal myotomy, which is also called heller-myotomy, as it has been described by the German surgeon Ernst Heller first in 1913. And since then, there have been published numerous variations of this technique over the decades and worldwide. And this myotomy is usually applied via open surgery, minimally invasive, or robot assisted. So far, the laparoscopic approach is considered most widely applied and considered the gold standard. Before you operate on your achalasia patient, there are a few things I want to talk about. Some authors administer their patient only liquid fluids or liquid diets several days prior to the operation to just reduce the risk of food infection. We don't do it necessarily here. However, what we do is performing an endoscopy prior to the operation to check or recover any retained food. I also advise to insert an oral or nasogastric tube of medium or big size prior to operation and just suck the esophagus thoroughly to get rid of any leftover fluids there. Also, this nasogastric tube can give you sort of a guidance during the operation as it has sort of resistance, and also it can help you perioperatively to check for any kind of mucosal damage or perforation. So, as I said earlier, the laparoscopic approach is currently still considered the gold standard. When you talk about the operation, of course, the patient is put under general anesthesia. We usually administer single shot perioperative antibiotics, which is here usually a combination of ampicillin and sulfabectam. For the positioning of the patient, it's more or less the same as for the fund application approach. The patient is positioned in a supine position. The operating surgeon stands between the spread legs of the patient, and the assistant as well as the scrub nurse are standing on the side of the patient. For trocar placement, as the patients are usually adolescent of age, we take a 10mm camera trocar to go through the umbilicus. However, if you have a smaller kid, you can also use a 5mm camera. For the working trocars, we usually use the 5mm trocars, which are applied on the left and right side of the middle of the abdomen. Again, if you have a smaller child, you can also use 3mm working instruments. I think it's quite helpful for the access of the hiatus to insert a liver retractor, which is usually placed on the right upper abdomen of the patient. And if you still have trouble with visualization, of course, you can still put in another trocar. So I quickly want to walk you through now through the steps of the heller-myotomy. first you have to find your way to the hiatus. You divide the gastrohepatic ligament, expose the diaphragmatic cruise, you divide, as seen here, the phrenoesophageal ligament. You expose the upper portion of the esophagus. It's important to watch out and save the vagal nerve. Intersect the left cruise from the left side of the esophagus. This should give you entry to the thorax cavity and should give you access to the mediastinal part of the esophagus, which again gives you an adequate exposition and length of the esophagus to work with. Also, it might be quite helpful to put a grasper through one of the working parts and just gently grab the stomach and just pull a bit to have good lengthening and exposure of the esophagus. On these sketches, you can see the start of the myotomy. Just you make a small, very superficial incision, only a couple of millimeters, round about 1 centimeter above the esophagogastric junction. If you use an electric hook or ultrasound knife, something which is current triggered, you have to make sure there's no thermal damage to the underlying mucosa, because this might result in a damage and perforation. Then you continue with a blunt dissection. Once you have this window, this opening field, you continue with the blunt dissection of the muscle layers. You can use either scissors or maybe forceps graspers just to gently divide the plane of the muscle fibers from the mucosa. Traditionally, you work your way first upwards towards the hiatus. Even with this, you might get access to the mediastinal part of the esophagus. Once you finish this, you go down towards the fundus of the stomach, and again here incise the fibers for a distance of round about 1 to max of 2 centimeters to make sure all the muscle fibers are thoroughly cut and leading to a good relief of achalasia symptoms. So this is an intraoperative photo and also a sketch. You can see here that once the muscle fibers are divided, just the mucosa really pours or pouts out, and you have very nice access to it. This is the final product once in the sketch, and also again an intraoperative imaging. On the top you see the esophageal myotomy, and down the fundal myotomy, exposure of the mucosa here. So what I told you step by step is hopefully now seen in this very short laparoscopic video. First we have to access the first incision of the muscular fibers. One, you have this access window. You can use it to divert the planes of the muscle layers from the mucosa. You work your way upwards towards the hiatus. Once you finish that, you go down to the fundus, and here you can see the whole length of the myotomy very nicely. In Hannover, traditionally, we combine the helomyotomy with an anterior fundoplication. We usually perform here a tal fundoplication. As you can see on this image here now, that the fundoplication also covers the defect of the myotomy. A couple of things to consider for the operation itself. If there's some bleeding during the myotomy, usually don't worry too much, as the bleeding usually resolves, just stops itself. If you are worried about potential mucosal perforation, you can ask the anesthetist to just insufflate some air, and if you find leakage somewhere, just put on some absorbable stitches. For afterwards of the operation, the nasogastric tube can be taken out directly after the operation. Usually the patient after the minimally invasive repair can start with liquids on the day of the operation once the anesthesia has worn out, and the oral food increase should be complete on the third post-operative day. The combination of helomyotomy and fundoplication has been seen quite controversial in the literature, not only for children, but also for adults. There are several studies, comparative studies, and for others also RCTs, supporting either way. What are the options you have for fundoplication? You can do a partial anterior one, which is either a DOR or a TAL fundoplication. You can apply a posterior wrap, which is a toupee, or have the wrap complete, which is a Nissen. For the younger colleagues who are hopefully watching, here a reminder about the kinds of fundoplication. You can have your wrap done with DOR is classically 180 to 200 degrees anterior wrap. TAL is 270 anterior wrap. This is what we do here most of the time. Toupee is also 270 degrees, but posteriorly. And the Nissen, if you combine the Nissen with helomyotomy, then usually it's called a floppy Nissen. You try to avoid to make it too tight to avoid dysphagia in these usually otherwise healthy patients. And also a lot of authors also recommend to not cover with the Nissen fundoplication your defect of the myotomy. So it's basically an almost 360-degree Nissen fundoplication. Now I want to say some words about the robotic approach. The usage of robot surgery has been proven useful and feasible and doable, also for children and helomyotomy. However, the reported data on robot-assisted children, Da Vinci robots, is very, very limited compared to the laparoscopic approach. If you look it up, and I just did in PubMed, if you search for achalasia and robot assistant, you find for children only 5 hits. However, if you search the same for adults, you get almost 100 hits. So the Da Vinci robot is way more frequently used in adults, and has proven its value there. However, doesn't matter children or adults. There are no RCTs comparing laparoscopic approach and robot-assisted helomyotomy by now. There are several case reports, technical reports, even a lot of comparative studies, but no RCT. So cautiously, there might be a trend that the use of robotic-assisted myotomy might lead to a reduced risk of mucosal perforation. Now, in Hannover, unfortunately, we don't own Da Vinci robot, but Martin was very kind and lent me some of his videos. So first you see the setup of the Da Vinci equipment in his operation theater in Leipzig here. And the next one, and I really hope you can see it as well as I do, is robot-assisted helomyotomy. And I always admire the crystal clear imaging we have here. So the surgical steps for robot and robotic surgery and laparoscopy are basically more or less the same. You isolate the esophagus, then you find you make a superficial incision to the muscle layers, and once you have the first steps separated the planes, then you go upwards to the hiatus and followed down by division of the muscular fibers of the fundus of the stomach. Here now you can see the whole myotomy very nicely. And Martin also told me that what you can see here, they also give some specimen of the muscle fibers to the pathology. Also, in this case, the myotomy is followed by a fundoplication. In this case, they performed the DOR fundoplication. This also covers the defect here. And this video closes with fixation on the crura and also closure of the hiatus to avoid herniation. Very nice. So now I want to leave the surgical part of the disease and talk a little bit about follow-up. Of course, all achalasia patients know it doesn't matter, the treatment should be seen regularly in your follow-up clinic. Usually they come after 1, 3, 6, and 12 months, or depending on the clinical symptoms. If you have a complete asymptomatic patient with any problems, of course, it's only clinical follow-up. However, if you have residual or recurrent therapy, you can think about medical therapy. As we heard earlier by Frederic, this obviously doesn't work and makes no sense. So if you have like reflux problems, then you can start at least with PPI. And depending on the symptoms and the problems, you have to reconsider pH-metry, remanometry, endoscopy, or a counter study as well. What's important, I want to give you as a take-home message as well, is if you have achalasia patients, it's crucial to make sure they have transition to adult medicine, as they have an increased risk for esophageal cancer, but we'll come back to that later. What to do in kind of recurrence, Frederic already also mentioned something of these topics. What you do with your patient really depends, in my opinion, whether you're a member of a surgical unit or a member of the gastroenterologist, internal medicine, and what the technical or the feasibilities in your department are. You can start again. It doesn't matter if it makes sense or not with medical therapy / PBIs. Yeah, you can think about Botox injection. Botox also has been shown to work after helomyotomy. Same applies to pneumatic dilatation, also works after Heller. If you're in a surgery department, you can do a Heller redo operation. This can be either laparoscopically open or robot assisted. Also, in the last years, POEM has been described successfully after primary treatment with helomyotomy, and also a redo POEM after initial POEM has been proven successful in the literature. So luckily for children, end-stage achalasia or severe achalasia requiring esophagectomy is very, very rare. However, if you ever have the case to consider to take out the esophagectomy, of course, you have to put in some sort of transposition, which is usually a gastric pull-out or some sort of colonic or this bowel interposition. I want to close my part of the webinar with a little bit of outcome reports. First, 2 systematic reviews. The first one deals with the laparoscopic helomyotomy. It has been reported in 2016 by the colleagues from London. 21 papers, more than 300 children, perforation rate of 9%, conversion rate of 3. Most of the included papers applied or combined the myotomy with a fundoplication, which was mainly a door technique. I find it quite interesting that the incidence of postoperative gastroesophageal reflux / dysphagia symptoms were quite similar, and didn't matter if they had a fundoplication prior within the operation or not. However, the number of patients were quite small, with only 1. They had 50% re-intervention rate, which were mainly pneumatic dilatation and redo surgery. So after reviewing their data and the literature, they concluded that the helomyotomy is effective in around about 85%. And however, a routine fundoplication might not justify it in children. The second systematic review is from 2019. It covered 33 papers and more than 700 children. Please note that out of the 33 papers, 25 dealt with helomyotomy and only 6 with POEM. The success rate was almost 80% for Heller and almost 100% for POEM, which was incredible. However, the complication rate was quite high, with almost 25% for POEM and very low with 5% for pneumatic dilatation. And further interventions were needed mainly for patients treated with pneumatic dilatation. So these colleagues concluded after reviewing their literature that helomyotomy is superior to pneumatic dilatation, which is also covers the same information or the same outcome that Frederic talked about earlier. And as POEM hasn't been on the market for very long in 2019, they conclude that POEM is quite promising, but the long-term outcomes were lacking by then. And I think in the discussion we probably come back to that, as there is now more data available. Let's talk about the cancer risk. I mentioned it earlier. As this study from 2010 with 450 patients from toddler's age to older age, all underwent pneumatic dilatation, and 3% of them developed esophageal cancer. This was mostly squamous cell carcinoma, but 3 also adenocarcinoma. The patients were mainly diagnosed at older age of 71 and around about 25 years after symptom onset. So the take-home message for you here now is that achalasia patients have a higher risk for esophageal cancer than the general population. However, the absolute risk for developing this cancer is rather low. I want to close my presentation talking a bit of quality of life. This is a Dutch study from 2016, 87 children who mainly underwent pneumodilatation and some helomyotomy. Retreatment rate, again, higher for pneumatic dilatation, however, more complications observed after helomyotomy. I thought it was quite interesting that while these authors performed their questionnaire, that almost half of all patients still had a positive EGOT score, suggesting an active disease. However, only a limited number of the patients were still on the follow-up treatment. Regarding the quality of life, the kids QOL was quite similar to the population, the normal population. However, for the adults, the quality of life was decreased compared with the normal population. So this was my part of the webinar. Thank you very much for your attention. I'm looking forward to discussion. Thank you.
This question is from Dr. Varun Hatiramani, and this was at the end of Frederic's presentation. Does your dose of Botox vary with the age or the weight of the child?
No, we use a maximum dosage of 100 units, as we did on as we do on pylorus. It's in 4 quadrants, and so you share the dosage in 4, and you inject with a sclerosing needle. So no change according to age. No, it's so, maximum 100. Maximum 100.
So Frederic, if I may ask you that, so in idiopathic constipation and Hirschsprung's disease, we inject usually 200 units in my center, and during the last ERNICA meeting in Madrid, most of the people would inject 100. So from a toxic point of view, 200 is no really problem, I wonder whether this would make a difference, because 100 is actually not so much.
Yeah, I agree with you, but the data are very limited in literature about that. So we follow what was reported as efficient, and what you see using botulinum is usually after 2 days or the day after the child is better. But the problem is that after 4 months, 3 months, 2 months sometimes, start again. So I'm thinking it's not a question of dosage, but it's a question of lasting of the effects, of the duration of the effects.
Right. Maybe true. That's the same with the Hirschsprungs after 2 to 3 months. Okay. Then there's another question, I guess, for you also, Frederic, from Zifi Kumar. How will you assess the length of your myotomy when you do POEM?
So it's a good question, and first, I have to, but it's very important, and thank you for this question. I do not perform myself POEM, and the reason is because it's very rare. I think we have to deal with adult GI. It's our adult endoscopic who is very trained in POEM in adults. As you can see in this series, and the Chinese series is 40 cases of children and 1,000 of adults. So adults endoscopic have very much experience, and I think POEM should be done by an experienced team, and I will never, even we are a reference center, we're working with our adult endoscopists. The adult endoscopists come in our pediatric wards and theaters, so he performs a child here in our wards, and the child is in pediatric environments. But I would really be reluctant to start to do POEM as a pediatrician gastroenterologist, even we are performing a lot of endoscopy and a lot of interventional endoscopy. I think the result is linked to the experience of the surgeon or endoscopist, and in this case, we decided to work with our adults endoscopists, which much more better. And even we start in a 5 years child with a POEM last year, and he came in our wards, and he was no problem in anesthesiology and so on. But I really think we have to focus on very experienced team. And to answer better to your question, I know only one center where is it a pediatric endoscopy who is performing POEM. It's in Rome, in Jesus Bambino Hospital. And they start working with the adult endoscopist and then started to be only pediatrician. So really, so I don't know exactly the technical question where to stop or what is the length. I know that they are very cautious to go down to the stomach to be sure that they don't lead a circular muscle at that time, which can explain still high pressure or the default of relaxation. But I don't exactly know what is the length of the myotomy, but it's matter. It's very important.
Okay, thank you. But I mean, working with the adult surgeons, even in a Heller, makes sense also because they're doing it every other day. And if we do it only a few times per year, it cannot hurt to do it together, especially in the robot. Then you can do 2 console surgery.
Absolutely.
Okay.
Question from Juan de Agustin, who asks whether you use, I think he's more at the end of the myotomy, and so I think maybe with the robotic one, but whether you use a flexible endoscope when doing the myotomy or at the end for leakage.
Probably a question for me, I think. I know that as some authors do it using the endoscope and also even perform intraoperative manometry to check whether the achalasia has resolved. However, we don't do it. We found it unnecessarily, and most of the textbooks I worked through by preparation for this webinar also think it's not nearly necessary. But of course, if you feel more secure and you have the access to it, you can do it and look for it. And also, I maybe want to add, at least because I forgot to mention it during my presentation, for the surgical myotomy, it usually the distance. The length you open is depending on the size of the child, from 4 to 6 centimeters, maybe when you have a smaller one, or more 6 to 7 if you have an adult-sized patient or big adolescent.
So from a robotic perspective, I can add, I think you just see it very well, whether you perforate it or not. And I would be really scared to perforate while I do the endoscopy. So to stick anything in there antegrately, I would not love that idea, to be honest.
Good point. Yeah.
You do this. I mean, with a lot of myotomies, I don't know if everyone does the same, but there are some techniques like the shoe shining maneuvers and people that inflate the stomach, holding the duodenum. There's ways to make sure that you don't have a duodenal perforation and you have an appropriate myotomy. This is, of course, another part of the GI tract. Is there anything that makes you sure that you're satisfied you have incised enough that the myotomy is appropriate? I'm asking Julia, Martin, you guys have done it also robotic.
I think it's like more the experience of the operating surgeon. So my former boss, Professor Ure, who did all the myotomies in the last couple of years, combined with the fundoplication, and he had, of course, after through this experience, he had the eye for it to check how much was enough and how deep towards the fundus or maybe into the medicine area he had to go. So I think what is the thing that Martin said, you need experience, and you do it more than once in 5 years to know what you do and how much is enough and how much is not enough. And I think Martin, who's working with the Da Vinci here, probably has even more experience here in this case.
So what we do, we actually do a 6 to 7 centimeter myotomy. We begin in the distal esophagus, then we go proximal first. You saw it in the video, but the Zoom does not project the video so nicely. I will, so in the edited video on the YouTube channel, I will insert that smooth video. And then it is important to do the myotomy in the fundus for 2 to 3 centimeters. And I think that's really key. And what we do, then we take a suture, which is 6 centimeters long. We put it in the abdomen and we document that this is the length of the myotomy. And this goes in the OR report also. I think that's really key to have an objective measurement what you did during the surgery. Yeah.
Good advice. Thank you.
There's a question from Streni Peck. How many days for in the nasogastric tube? How many days do you leave it there?
After the laparoscopic approach, we usually take it out immediately after surgery, and I think this applies as well for robotic assisted, probably. Mm-hmm. So usually, if it's performed minimal invasive, you just can take it out and start fluids on the same day.
And then there's the question from Mohammed Sharif. What should we do if there's a tiny perforation in the mucosa during open halar myotomy? During open. Julia, do you want to comment on that?
I haven't been witness of an open halar during my time here in the department, to be honest with you. But I would say play it safe and put a suture on top. What do you recommend? Right,
that's what we do. We do a 5-0 monocrol or PDS to close that, and then we do a blue test in the end to make sure it's, yeah. Okay.
Question from Bilal. Can we diagnose achalasia based only on the manner of the lower esophageal tone in endoscopy?
Should I answer this question?
Please.
No. You absolutely need to have a manometry, and there are 3 major signs. The first is high pressure, a relaxation abnormalities of the lower esophageal sphincters, and always a dysmotility of the esophagus. So in the Chicago classification, the 3 signs has to be associated. What is difficult is in small infants, we have some cases of we have reported 20 years ago a series of small infants with severe dysphagia and some features at manometry on achalasia, but incomplete with very small, teeny dysmotility, or pressure was not so high and so on. So in that case, we tried for adalat nifedipine and wait for a bit. And what we observed is 50% of them become true achalasia and needs to have a myotomy later on, but half of this case resolved spontaneously, and there we're able to feed again and with no treatment and very easy follow-up. So really, I need that high resolution manometry is really the gold standard, and you have to have these 3 signs to be sure of the diagnosis. In other way, if it's incomplete, you have to wait for a moment, repeats as examination, or rule out differential diagnosis. I mean, there are some spastic esophagus at motility. There are some extrinsic compression. So if it's not typical on your manometry, you should wait before going to myotomy and try to search for other diagnosis or repeat, say, manometry 3-6 months later to be sure that it's a real achalasia.
Okay, then there's a question from Farid Edalagi. What are the histopathology findings?
Usually it's fibrosis, and it depends on the stage. But when it's a typical achalasia, you have fibrosis, you have abnormal. If you made some special staining for nerves, you can see that nerves are abnormal or in a lower rate. And a muscle is at the first part is deeper, and then is fibrosis inside.
Okay, I can really echo you, because I think that's really key to take that biopsy, because in a lot of cases you see the loss of the ganglion cells, supporting the view that it's a primary esophageal disease with ganglion cell depletion and not something else. And then you have the proof that you really did, especially if you fail or you get a recurrence, you can prove that was achalasia, right? What I did there.
Yeah.
And then you feel better.
There's an anonymous attendee that asks, when can I say clearly that the medical management has failed and I have to find another means for management?
So if medical management, you mean drugs? No drugs is working. So an Adalat is very, very partial and transient treatment. So except for a very rare case of infants, I would say no medical treatment. If you talk about botulinum toxin, Botox, it's not the first step, and all consensus are it's only for rescue treatment or difficult case. You have sometimes children with total Hirschsprung and achalasia and central hypoventilation being in intensive care unit, so nobody wants, for ethical reason, to go to too much treatment such as myotomy, either endoscopic or Heller. So in that case, you can use that, but it's transient, of course. And of course, dilatation is also, as our experience is that the child is better within a few days, but after several months, all of them go back to symptoms. And in our world and in our experience now, if I have a typical case of achalasia, whatever the age, I will go to a myotomy and discuss with our surgeon and endoscopist if we decided to go to POEM or if we decided to go LR.
And still on the Botox, where do you inject? What are the sites for a Botox injection?
Oh, it's purely in the cardia in 4 quadrants. So you insert the needle, and when you inject, you see some a white part, some edema around. So you are sure you have to inject deep in the mucosa. So deep. It's not you have to insert the needle close to the end of the channel. And then you inject and see some white part and edema, and then you are sure you are injecting at the right part.
Do you also add blue dye to it, Frederic? That you
No,
see?
no, we are not used on that. Some people use it, but we don't do it on routine. No.
Okay. And then there's a comment from Zimvakuro. What he does is based on the vertebral level of the barium swallow, and in a case that it's too long, that one cannot expect for a complete myotomy with a laparoscopic route, he goes to the thorax and does a thoracoscopic approach, I guess, to do a longer myotomy. Does anybody does that? Well, to my experience, you can go pretty far from the laparoscopic route. You can dissect especially if you widen the hiatus a little, you can go very high up. But maybe it's a good idea to go to the thorax. I'm curious what everybody else thinks. I've not done it.
I don't have experience with that either. There's a question about whether we recommend the child, when you recommend the child to start eating after the Heller myotomy. Julia,
Usually, yeah, fluids on the same day, drinking, and then usually the next day start with some fluid food like yogurt or pudding, for example, and if it's tolerated well, you can switch to light toast and then just increase depending how well the patient tolerates the feeding. That's what we do.
Then there's a question about esophageal exclusion. In what cases do you do that? I have no experience with that. This would be sounds very definitive to me. But
I agree. I don't think usually in children the situation gets this worse. I think it's more described more often in the elderly patient for severe cases. So I haven't seen it here as well, luckily.
But that is
at least not for achalasia.
And then there's a question, I think for everyone, but I think maybe for Frederic, about if the patient is syndromic, the presence of a syndrome does it affect the type of treatment, endoscopic or surgical?
I would say no for AAA syndrome with achalasia, lacrimia, and adrenal insufficiency, which is a rare forms and genetic forms. We are going to myotomy as a first-line treatment. As for the other form, what I have to say is that AAA symptomatic children are very poor outcome. A lot of these children fail after treatment and need a redo, myotomy, dilatation, and so on. And there have been 2 papers. It's very, very, very rare. So there have been 2 papers, one from our group and one from a German group, looking at AAA compared to classical achalasia patients. There are no difference in terms of manometry, but the outcome was in these 2 small series very different, and a lot of redo surgery, a lot of gastrostomy support needed for these children. So probably the same treatment as the first line, but to be more careful than for the other one about relapse or failure of treatment.
Thanks. We had a similar question on the webinar chat. We have 2 ways for the attendees to pose questions through the Q&A chat and box and also the webinar chat. And there was one from Oscar, let's say from Italy, about the AAA syndrome. I see one from Sandra Montedonico from Chile. What would be your tips for a redo Heller myotomy?
The question is, do they mean for diagnostics or just operation in general? I mean, it depends how quickly there's recurrence of the disease after the first operation. Is it just not resolved at all? Also, is it also a question for me, has the first operation been performed in our clinic or somewhere else? Because as we talked about, you need a lot of experience to do the Heller myotomy. And if you only see like 1 case in 5 or 10 years, of course, it's easier to make it incomplete. However, I think there are no special tips. You have to really think about whether a redo Heller myotomy is the right choice for this patient. When special cases like this, we have not only like this, but gastrointestinal questions in general. We have an interdisciplinary panel, not only pediatric surgeons, but also gastroenterologists coming together, discussing the patient, the history of the patient, any additional diseases, and then we decide together whether the redo Heller is the best option, or maybe we should just try less invasive treatment, for example, like Botox or pneumatic dilatation, but maybe 1 or 2 pneumatic dilatations will resolve the problem before putting under a retrosurgery, which is usually or always way riskier if you have to go in there a second time due to the scarring and the risk of injury. So my advice would be to plan it very carefully, really check whether this is the right solution for the patient, and otherwise just make sure that your preoperative planning is on point. So maybe redo first all the necessary diagnostics. Doesn't matter if you have redo endoscopy, pH metry, whatsoever, to make the right choice for the patient, and then really have an advanced surgeon do the redo surgery.
I mean, in addition to what Julia said, these are really tough cases. So what you don't want to do is a perforation, right? So you don't want to use a lot of thermic energy. You want to even take a little swab, like from some nose when you have a congested nose, right? So this substance there, you can put on a swab to do some not coagulation, but sort of to see better. And then definitely you want to add a door fundoplication, especially in all the cases where you're concerned of perforation. It's a very high risk of running into big trouble when you don't do the fundoplication. That's what I think. If you have a perforation, you sleep better when you know the fundus of the stomach is on top of that perforation.
Frederic, you had your hand up.
Yeah, just want to add a point of view. I think when you are facing a failure of the first treatment, whatever the treatment is, POEM or myotomy, before going to a second step, you have to repeat high resolution manometry because it can show you what is the pressure of the less, and if and to try to answer the question if the myotomy was insufficient, was not complete, and then it remained a high pressure, or if the pressure is very low, it could be the child can be symptomatic because of the motility of the corpus, of the dysmotility of the corpus of the esophagus. So before going up in the treatment to a second or third step, or redo myotomy or POEM after Heller or Heller after POEM and whatever, would repeat a manometry, high resolution manometry to see that. And I would just like to add, I see a question about the future in achalasia, and there are a new tip, which is endoflip. Endoflip is a type of a planimetry you can introduce during endoscopy in a child sleeping, and it's measure the impedance of the lower sphincters, and also can measure the distensibility of the esophagus and motility of the esophagus. And there are very interesting but preliminary data, at least 2 papers recently published, showing that this could be helpful to decide what type of new treatment you have according to the distensibility of the lower inferior sphincters. Even in performing this measurement during your surgery or during the POEM. So it could be a nice tip. This device is now available for children, the 4.0 version, which is more adapted for small children. And I think we would have a more functional test to see what happens if the failure, or to follow treatment or retreatment in this case.
All right. So thank you, Frederic. Thank you, everybody. I think we need to close the session because we are approaching the 90 minutes. We're still 97 delegates watching us. Thank you very much for the excellent talks, Julia, for your surgical talk, and Frederic for the GI talk. The next webinars will be November 29 and December the 6th. The first topic is esophageal stenosis and how to treat that. And the other topic is artificial intelligence in pediatric surgery. So stay tuned with us. Thank you, Augusto, for co-chairing this session with me. Thank you also, Gaia. I think she had to leave for another meeting. The edited video will be uploaded on the EUPSA YouTube channel soon. And yeah, everybody have a great day and see you next time.
Thank you so much. Thank you. Bye-bye.
you for your time. See ya. Bye-bye.